Hi all of you, INICET PG May 2024 surgery questions and surgery recall questions. What are the questions asked and how about the question and analysis? The surgery with regard to this exam is looking straightforward and easy questions, and you can attend all the surgery questions and it is easy. Question 1 reads, which needs immediate attention in triage? Is it black, red, yellow or green? The right answer is red, because the immediate action is required for red color code and it's a life-threatening illness, and yellow is delayed and serious but not life-threatening illness, and green is minimal, it's minor illness or injury, walking wounded, and third to treat, and expectant is black, is not expected to survive. So immediate is first to treat, yellow is delayed, second to treat, green is minimal, third to treat, and expectant is black, the patient is not expected to survive. This question reads, Crohn's versus ulcerative colitis, what are the similarities? Option A reads continuous involvement. Continuous involvement is seen in ulcerative colitis. Perianal stricture is both seen in ulcerative and Crohn's, but most commonly seen in Crohn's disease. Colonic cancer, the risk is seen in both with ulcerative colitis and in Crohn's disease. And frequent hematochezia is most commonly seen in ulcerative colitis. So the right answer could be option C. The risk of colonic malignancy is both similar and same duration, and the risk is the same. And they can ask you one more question in upcoming exam. The histopathological hallmark of ulcerative colitis could be cryptopsis, it's of neutrophils. And in Crohn's disease, it's going to be non-cascading granuloma, which is made up of macrophages. Okay, epithelioid histiocytes and lymphocytes. Question reads, Mont-Fuji sign is seen in. It's a very simple, straightforward, factual question. The right answer is pneumocephalus. And the most common cause of pneumocephalus is trauma. And the one of the most common causes in trauma is could be iatrogenic, it could be a craniotomy, could be a head injury, where you can see air in the skull, within the skull, and you can also, this can be expected even in the abscess, could be an anaerobic abscess, could be caused by Peptostreptococcus, and those kind of organisms and abscess can also cause pneumocephalus. But one of the most common cause is trauma and craniotomy. This question reads, a 35-year-old male sustained with a head injury following a motorcycle accident, experienced a brief loss of consciousness, so history of loss of consciousness is there, LOC, and upon regaining the consciousness, he developed a severe headache and began feeling drowsy. A CT scan showed in the image here. And which of the following should be the management of choice? See, the CT scan clearly tells you it's a biconvex lenticular shaped hematoma. See, this biconvex lenticular shaped hematoma is classically seen in extradural hematoma. An extradural hemorrhage is because of the rupture of middle meningeal vessels, and it could be the fracture of the pterion, the thinnest portion of the skull bone, and the treatment could be the immediate evacuation of the clot, could give him best results and best prognosis. And the lucid interval is very, very important in extradural hematoma. And they can also ask you about the subdural hematoma. The subdural hematoma could have a thunderclap headache. So again, a frequently asked exam question. Okay, so immediate evacuation of the clot would be the appropriate answer for this question. And anticoagulants, observation ICU and mannitol could all have some benefit, but definitely not anticoagulants. Bezostrol could have some benefit only after the evacuation of hematoma. Okay, this question reads, thoracic stab injury, and following that, the finding in the X-ray. See, the finding in X-ray, you're able to see the right lung and the left lung, and you see the left lung, there is a white shadow. See, whenever you see white and the lung is collapsed, and then it is always a hemothorax. And classically, it's a stab injury. So, injury to the thoracic vessels could have caused the accumulation of blood in the pleural cavity to cause this white appearance in the X-ray. Now, it's going to be a pneumothorax. How to differentiate pneumothorax or tension pneumothorax, hydrothorax? See, hydrothorax will usually have a air fluid level, and the pneumothorax, it will appear as black. See, it will appear as black, and the lung will get collapsed towards the hilum. This is pneumothorax. See that? Lung gets collapsed towards the hilum, it is pneumothorax. And rest of the entire will be uniformly black. And if it is white, it is hemothorax, and it's black, it's pneumothorax. So tension pneumothorax, you need to put a wide bore needle in the second intercostal space, followed by the intercostal drainage tube in the triangle of safety. Yes? So very, very important question for exam. Question reads, ER positivity is used as which of the following in the context of breast carcinoma? Always, it is a prognostic marker. The right answer is, it's a prognostic marker, because ER-PR status and HER2/neu status is very important to manage the management and treatment, and to plan for giving chemotherapy, giving hormonal therapy, to plan the entire management following a definitive surgery or definitive radiotherapy. So, ER-PR status can be assessed by a true cut biopsy. The minimal amount of tissue that is required to calculate ER-PR status is 1 gram of tissue, and you should know, is it ER positive and PR positive, or ER positive, PR negative, or HER2/neu positive or negative, because if all ER, PR negative and HER2/neu negative, is called triple negative breast cancer, because it has a bad prognosis or poor prognosis, because most of the drugs may not work for them, and you should know about the hormone receptor status and determines the prognostic indicator. They can also ask you the most important prognostic indicator for breast cancer is always the answer is lymph node status. So lymph node status is the most important prognostic indicator for breast cancer. Now in this given question, it is the ER receptor or hormone receptor status is a prognostic indicator. This question reads, invasive ductal carcinoma presenting with ulceration in the skin, inflammatory signs and nipple retracted, what is the stage? See, it's very clear, the ulceration of the skin belongs to, it is T4B, and inflammatory signs belongs to T4D as an inflammatory carcinoma of the breast. So it will go for the staging according to the options given here. The right answer will be stage 3B. So it is very clearly evident that the chest wall involvement is T4A and involvement of the skin is ulceration or ipsilateral satellite nodules or skin edema or pudgy orange is T4B, and T4C is both A and B, and T4D is inflammatory carcinoma of the breast. So whatever might be, the stage grouping will come to stage 3B. It is locally advanced breast cancer. In another exam, they also ask you about T1A. T1A is less than 5 millimeter, and T1B is 5 to 10 millimeter, and T1C is 10 to 20 millimeter. In conversion, centimeter will be 1 to 2 centimeter. Again, T2 will be 2 to 5 centimeter, and T3 will be more than 5 centimeter. And T1 micro will be less than 1 mm or less than 0.1 centimeter. Understood? So staging of breast cancer is always an exam question. You should definitely have a look at it for the upcoming exams as well. This question reads, primary survey does not include which of the following? The right answer will be a CT. Because primary survey, all of you know that it is DRS and ABCD. D stands for danger and R stands for response and S stands for send for help. And A is for airway, breathing, circulation, that is CPR, it's not just circulation, CPR, and D for defibrillation. Understood? And now what are the adjuncts to the primary survey and resuscitation? Definitely to maintain oxygen for hypoxia, I need a pulse oximeter to monitor it and know the vitals to BP monitoring, and ECG to look for the cardiac stability, a nasogastric tube aspirator and urinary catheter to look for the urine output, and also the ventilator rate, so you should know the ventilation status, and the ABG levels, and X-ray of the chest and pelvis to look for the fractures and multi-fractures, and also FAST. Okay, focus assessment sonography in trauma, and DPL is diagnostic it's query, but most centers use FAST. So these all are required. So to a given question, and ET for ventilation and chest X-ray to assess in case there is a trauma, and in a chest to X-ray to assess, chest X-ray, intercostal drainage tube in case there is a pneumothorax. So all this might be required except for a CT, probably will be required for secondary and tertiary surveys. Not true regarding, question reads, not true regarding the breast, anatomy of the breast. Now the superior medial quadrant has more tissue, wrong, because the superolateral quadrant has more tissue. That's the reason why breast cancer is also more commonly seen in superolateral quadrant. And 10 lobules can be present, yes it can be. The tail of Spence, axillary tail of Spence crosses the anterior axillary fold, yes it could be right. You can see there from this picture, the most common location of breast cancer is upper outer quadrant for the reason that upper outer quadrant has more volume of tissue. The second most common location of the breast cancer is the central quadrant, this is nipple areolar complex. Now you can see the architecture of the breast. It is a subcutaneous organ and it is a modified sweat gland, and you can see the suspensory ligament of Astley Cooper that goes from the pectoralis fascia. See, pectoralis fascia and divides the entire breast into various lobules. Within the lobule there are acids and drained by the ducts that opens into the nipple areolar complex. And you can also see the blood supply to the breast. Yes, and this is about the fibrofatty tissue which you could see in this picture. Clear? So any malignancy here, infiltration into the duct can cause retraction of the nipple, infiltration to the suspensory ligament of Astley Cooper can cause dimpling of the skin, and direct infiltration to the skin can cause ulceration or satellite nodules, or involvement of the dermal lymphatics can cause pudgy orange. All these are signs of malignancy. Clear? This question reads, which of the following is the most common hernia in females? The right answer is indirect inguinal hernia. See, it be for men or women. See this picture, there are various types of hernia in women. It's about the epigastric hernia, an umbilical hernia, an incisional hernia, and a femoral hernia, an inguinal hernia, could be direct, indirect, and lateral hernia. Of these hernias, the most common hernia in men is again indirect inguinal hernia. In women, again it is indirect inguinal hernia. It's very clear. They can ask you what is the second most common in men, it could be 27.4, it is direct inguinal hernia. In women, it's going to be incisional hernia. Understand this. So number 1 will be indirect inguinal hernia in women, and number 2 will be incisional hernia if in case they could ask you in your exam. And the third would be umbilical hernia. Understood? So this could be very important. So in women, number 1 will be indirect inguinal, number 2 will be incisional, number 3 will be umbilical. In men, it could be number 1 is indirect inguinal hernia, and it could be direct number 2, so direct number 2, yes, and number 3 will be the combination of direct and indirect. Okay, could be asked next exam. They can also ask you what is the most common hernial content. The answer is the most common hernial content is peritoneal fluid. Understand this. The question reads, cholangiocarcinoma causes or includes what? The answer is Carolus disease, yes. Hepatitis B, yes, could be a risk factor. And ophthyosis vernuni and primary sclerosing cholangitis. See, all these are risk factors. See, it's all from standard textbook of Bailey 20th edition, all very clearly says, could be congenital biliary tract anomalies or Carolus disease or cholelocol cyst, autoimmune disease or primary sclerosing cholangitis or primary biliary cirrhosis, ulcerative colitis, bacterial tract infections with parasites, or could be hepatitis B and C or HIV, or recurrent pyogenic cholangitis, and toxins of thorotrost, chronic alcohol abuse, tobacco, dioxin, and polyvinyl chloride. All these are risk factors for cholangiocancer. Okay, so all the answers are right. Now the question reads, 20-year-old chronic alcoholic presents with severe hematemesis, ultrasound shows dilatation of the portal vein and liver appears hyperechoic, pantoprazole has been initiated, and so what is the next appropriate step? So it's very clear, it's alcoholic history and the portal vein is dilated. It could be a portal hypertension and could be a varicose bleeding. So the best could be to do an upper G endoscopy to see and confirm it's because of varices or because of peptic ulcer disease or duodenal ulcer, gastritis or congestive gastropathy. You should first ascertain cause. Even though it could be a portal hypertension, still the other causes could also be there. So just confirm it is because of varices. If it is varices, either try to do a ligation of varices or do a sclerotherapy. And if it does not work, and the treatment of choice for acute varicose bleeding will be TIPS, transjugular intrahepatic portosystemic shunt. If it doesn't work, the expertise is not there, then you go for DEVAS, Shiguras procedures. Okay. So you can see that endoscopy could be the initial investigation of choice to ascertain diagnosis and also to look into it and treat accordingly if it could be a varices. This question reads, patient with food regurgitation and dysphagia, halitosis and weight loss. This is a classical triad. Yes, this is a classical triad of achalasia cardia, provided this image is given like a bird's beak appearance. If the image is not given, it could be a difficult diagnosis between Zenker's diverticulum and achalasia cardia because both present similarly. Both has the three same kind of presentation, and in this question, if this image, if it is there, the answer is achalasia cardia. Okay, and you can typically see a bird's beak sign. You can see a bird's beak sign, and if in case they give a rat tail appearance, mostly it will go for CA esophagus. CA esophagus, understand this. And even in achalasia cardia, you will have a dilated esophagus, and it's called sigmoid shaped. It could be a sigmoid shaped dilated esophagus. And could be a double track sign, tram track sign, because of thickened esophageal wall. Okay, tram track sign. Okay, tram track sign. So this is all about tonically contracted lower esophageal sphincter to cause achalasia cardia and failure of relaxation and aperistalsis in the body of the esophagus. And treatment of choice, yes, treatment of choice today is POEM, peroral endoscopic myotomy. Probable exam question next time also. Which of the following is or complication of GERD? So it's a very straightforward question. All these are complications. So pulmonary fibrosis, laryngitis, asthma and chronic cough. Again from the standard textbook of Schwartz, textbook of surgery of 11th edition, which very clearly says could be asthma would be there, pulmonary fibrosis could be there, laryngitis could be there. Yes, so what is the other option? And chronic cough, chronic cough. See, straight direct question taken from that. And all this are extra, see the question, extraesophageal cancer, 11th edition of Schwartz. Okay, it gives pharyngitis, sinusitis, otitis, hoarseness, vocal cord granulomas, subglottic stenosis, laryngeal cancer, dental erosions, cough, asthma, yes, and chronic bronchitis, pulmonary fibrosis, aspiration pneumonitis and sleep apnea, what not, everything. And esophageal causes could be esophagitis stricture and Barrett's esophagus produced to adenocarcinoma, right? It can proceed to adenocarcinoma and esophageal cancer. Straightforward question. Next question reads, which of the following is not a marker of GIST? The right answer for the question is nestin, because c-KIT, SDH and PDFG, all these are markers. All these are markers. You can see that c-KIT, CD34, S100, Desmin, SMA, DOG1 and PDGFR and Vimentin. All these are markers, molecular markers for GIST. Gastrointestinal tumor arises from interstitial cell of Kajal. And try to understand this GIST tumor are most commonly seen in GIT in stomach. And one of the most common site of distant metastasis is liver. It known for multiple recurrences. And c-KIT antigen molecular biology positive, we can give imatinib. And imatinib, you can follow it with the second line sunitinib. If imatinib resistant, you can give dasatinib. So GIST is a very important entrance question. Match the following among the options given here. What it looks like, it's good. Straight away the question is H. pylori with GI maltoma. And H. pylori is one of the most common cause of GI maltoma. And it acts through CAG-A and CAG-B through B lymphocytes and tumor infiltration T cells and TREG cells to produce malt. and maltoma H. pylori, and one type of gastric lymphoma treatable by antibiotic is low grade maltoma. In case they ask you the most common type of maltoma in stomach, yes, diffuse large B cell lymphoma. Okay, it is NHL. So don't get confused. So H. pylori, malt lymphoma, very famous popular topic in gastric. At the same time, the most common type of lymphoma is NHL and it is diffuse large B cell. Understand this. The image given, what is the type of tube? It is there as an image based question. The answer is PEG. It's a type of access for the nutrition. There are various type of nutrition. You can give a nasogastric, nasojejunal, type of feeding, or feeding jejunostomy or feeding gastrostomy. See, this PEG, that is a modified feeding gastrostomy. That is done under endoscopic guidance, not through a formal kind of a surgery, which in previously an open surgery. Today, with the guidance of endoscopy, you will be able to locate where you need to puncture percutaneously. Like you put an SPC, right? SPC, suprapubic system, something similar to that. That you put it in the stomach under the guidance of an endoscopy inside and with a light access and through where you need to puncture and like a railroading system that you can put with a balloon which is inflated like a Follis. Like the bladder, it's like you can inflate this within the stomach and you can anchor it to the anterabdominal wall. This is for feeding. It's like a feeding gastrostomy. Is a PEG placement. It's called PEG tube. Okay. Aneurysm treatment. I have not seen the question where is the aneurysm, what type of aneurysm, but all these are type of treatment for any aneurysm in different parts of the body. It could be a bare stent, yes, or could be a coiling or embolism. Answer is all of the above. I can show you. See, this is aneurysm with the neck, so that you applied a clip, microsurgical dissection application of clip, and this is an aneurysm without a neck, so you need to put a coil embolization, and this is an aneurysm in the aorta that you put a covered metallic stent. See that? So endovascular repair. So it's an endovascular repair. So all these are the treatment options that are available for aneurysm. And these are looking like a berry aneurysm, this is an abdominal aortic aneurysm. So whatever might be, all these are type of treatment for aneurysm. The question reads, 25-year-old male came to the emergency department due to the trauma, hypertension, specific blood group not known, what to transfuse. See, there is something called universal donor and the universal recipient. Yes, the universal donor is O blood group, in particularly O negative. And the universal recipient is AB positive. I just want to know in what context it was asked. Is this context was asked as the recipient or as a donor? Yes, if it is going to be a donor and the donor he can donate is O negative. See that it can accept it by all the blood group. And if you see the recipient blood type, it is the AB positive that can accept, yes, all the blood group. So AB positive is the universal recipient and O negative, yes, O negative is the universal donor. So with regard to what context this question was asked, I think you should answer accordingly. My context is with the donor perspective of what blood from donor it can be given, it could be O negative. And if what blood recipient can accept, if that is the concept of the meaning of the question it is there, then it should be AB positive or AB blood group or AB positive in particular. See that? Okay. The question reads, all of the following statements regarding Wilms tumor are true except. See, the right answer for this question is majority of patients recover due to chemotherapy and radiotherapy. See, try to understand Wilms tumor patient typically presents as asymptomatic abdominal mass. Yes, diagnosed by the mother. When bathing the child, it presents with hematuria, fever, generalized weakness and fatigue and nausea and vomiting and loss of appetite. Generalized feature of the tumor. But Wilms tumor is predominantly treated from stage 1. Stage 1 is tumor confined to the kidney, completely excised. Stage 2 is tumor outside the kidney, completely excised. Stage 3 is incomplete excision without hematogenous distant metastasis. Stage 4 is distant metastasis. The most common side of distant metastasis is lungs. And stage 5 is a bilateral tumor. Whatever may be the stage, the treatment is a radical nephrectomy and followed by adjuvant chemotherapy. That means stage 1 will give 1 drug of vincristine for 3 months. Stage 2, you give 2 drugs of vincristine, actomycin D for 6 months. And stage 3 is give vincristine, actomycin D and adriamycin for 12 months plus radiotherapy to the flank. And stage 4, the treatment will be the same as stage 3 plus the radiotherapy to the lung because the lung is the most common site of distant metastasis. And stage 5, the treatment is nephron sparing surgery. That means the radical nephrectomy or nephron sparing surgery is done for the stages of Wilms tumor. Radical nephrectomy is done from stage 1 to stage 4, whereas nephron sparing surgery is done for stage 5, that is bilateral Wilms tumor. Understood? So primary treatment is surgery and followed by adjuvant treatment is chemotherapy or radiotherapy. Clear? 55-year-old male patient presented with the lower lip weakness following a recent parotid surgery. What is the most commonly likely lesion causing this condition? See, try to understand. This is a injury to the buccal branch. Yes, that supplies the lip, the upper lip or the lower lip. And the buccal branch is not given in this option given here. Is the main trunk of the facial nerve, temporal branch or cervical branch, apparative branch. I feel something options I have missed in collecting it. And I mean, it can't be a facial nerve because when facial nerve is injured, the entire muscles on that side will be paralyzed. It is not just the lower lip. So this is a query, right? But it could be a parotid branch, say, or because, what do you mean by this? Because this buccal branch that runs, the buccal branch that runs just superior to the parotid duct. There is a senescence duct. Okay, injury to the parotid duct can also injure the buccal branch, and that could cause the paralysis of the lip. Could be a possibility because the question that is asked in entrance exam other than this is the retrograde dissection of facial nerve is done through which branch? The answer is buccal branch. The buccal branch is closely associated with parotid duct. If the injury is to the main trunk, and then all the muscles of the facial muscle expression of that side could get paralyzed. Understood? So you need to just check what question was asked and answer accordingly. Understood? Yes? So, but I am giving you the facts that the buccal branch, if it is there, will be the appropriate answer. And if not, and you need to look into the individual branch in the facial nerve trunk. Understood? 45-year-old female presents with the recurrent episodes of right flank pain, hematuria and a history of urinary tract infection. Urine analysis shows alkaline urine. So, the stone that is formed in alkaline urine and with this shape, the coffin lid appearance. It's a true white calculus, calcium, ammonium, magnesium, phosphate. It's a triple phosphate calculus and it's a silent calculus. It's a asymptomatic calculus and the most common infecting organism is Proteus and alkaline urine, urea splitting organism, radio opaque shadow, dirty white in color. All these are calcium phosphate, triple phosphate calculus. There are various shapes could be asked in upcoming exams like calcium phosphate, like a fan shaped crystals. And could be a triple phosphate coffin that could see right now. Cholesterol could be rectangular plates. And an envelope could be calcium oxalate dihydrate. Okay, hourglass calcium oxalate monohydrate. Okay, this could be some of the exam questions. And cystine hexagonal. Okay, and onion ring appearance. Concentric ring is about leucine. Okay, or xanthine calculus. And barrel shaped or diamond shaped is uric acid calculus. So all this needle shaped tyrosine calculus. So all this, some of the questions are amorphous. Calculus could be urate or phosphates. You can expect one question in future exams as well. Aneurysm with connective tissue degeneration. The right answer is Marfan's and Ehlers-Danlos. Atherosclerosis is degenerative. See, what are the causes of aneurysm? Here I have made as a coronary artery aneurysm because the question, I don't know what is mentioned, it is just an aneurysm. Then I took a coronary artery aneurysm, it will be more important reference point. Could be a vasculitis, Kawasaki, Takayasu, SLE, giant cell arteritis, and Behçet's and others. And compensated dilatation of postcoronary dilatation, fistula and coronary anomalies. And Al-Kappa is one of the most important cause of MI in children. They can ask you this. MI in children is Al-Kappa. Abnormal left coronary artery arising from pulmonary artery. Connective tissue disorder is about the question here. Connective tissue disorder, Marfan's, Ehlers-Danlos, cystic medial necrosis and neurofibromatosis. The next could be the mycotic, drug abuse, trauma and percutaneous coronary interventions. All this could be the other causes. Okay. Which of the following will not result in hoarseness of voice after thyroid surgery? See, hoarseness of voice is because of the injury to the recurrent laryngeal nerve, correct? Yes, where recurrent laryngeal nerve is injured. Recurrent laryngeal nerve will be injured in dissecting and retracting strap muscle, exploring the birth triangle and triangle of Zucker candle dissection. Yes, in all this can be. But it cannot be in ligation of superior thyroid artery because in superior thyroid artery the relation is with the external laryngeal nerve, not with the recurrent laryngeal nerve. So, the recurrent laryngeal nerve is closely associated with the inferior thyroid artery ligation. Understand this, inferior thyroid artery ligation. Okay. So, recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx, yes, except cricothyroid. Because cricothyroid is supplied by the external laryngeal branch of the superior laryngeal nerve of vagus. Okay. So, the function of cricothyroid is tensor of the vocal cord. Understood? And this is a very, very important question. So, all the intrinsic muscles of the larynx except cricothyroid is supplied by recurrent laryngeal nerve. And recurrent laryngeal nerve injury can also cause hoarseness of voice and that is closely associated with the inferior thyroid artery, and also very important that the inferior thyroid artery predominantly supplies parathyroid gland also. It could be an expected question next exam. So, we have done the discussion on the questions that are asked in surgery, and these are simple, straightforward questions which are asked repeatedly from the same area, and I wish you all the best for the subsequent NEET PG exam on June 23rd. Keep going, wish you all the best and all the success.